We are going to go ahead in just a minute and get started with our poster presentations. I am going to take the slides down so I can get the first video up and running.
I'm just so excited about this part. Some awesome residents.
And I think John is on, so I will go and there he is. I'll pin him.
Yes, thank you all for having me.
Yeah, of course. We're happy that you submitted. This is our, first conference, first time doing poster presentations, virtual. So we're happy that you submitted. All right. Do you want to introduce yourself before I go ahead and play your video?
Sure. So I'm John Block, Little Rock native, lived here since I was 3, went to UMS for undergraduate, was really glad when I was allowed to stay for residency at Arkansas Children's. And yeah.
Perfect. Thank you. And I will go ahead and share your video. Make sure I share sound so everyone can hear it. And Anna, give me a thumbs up.
Thank you for allowing myself and 4 of the most driven medical students I've encountered to present on our goal of providing clean water for the natural state. In fall of 2019, when I was on my internal medicine rotation, I met with a man who'd been hospitalized for months with a complicated pneumonia. As we prepared to discharge, the attending asked what he would do for food and water. He kind of shrugged it off and said he'd get by like he always had and drink quilt water. When asked what that meant, he mimed wringing out a blanket into his mouth. When I heard that, I knew that we should do better as a society to protect the vulnerable members of our community. I brainstormed with some classmates and someone mentioned life straws, which are used by avid outdoors lovers to be able to drink from streams, and the idea of this grant was born.
Water insecurity is defined as lack of availability of sufficient water of good quality to meet basic human requirements. And this goes hand in hand with homelessness. Every day in Arkansas, around 3,000 citizens are without shelter, and about a third of those are right here in Pulaski County, where we're all currently completing our medical training. An ever-increasing percentage of those without shelter are minors, which can occur for a number of reasons, from financial stresses to household disagreements, and particularly affects young members of the LGBTQ population. Waterborne gastroenteritis is responsible for 2 million illnesses across America every year, and leads to over 10,000 hospitalizations annually.
The financial cost of the healthcare sector is $160 million each year from what is by and large a preventable cause. The average cost of a hospitalization is over $10,000, which could provide upwards of 1,000 life straws and subsequently 3,000 years of clean water to individuals experiencing water insecurity. The filtration units themselves are simple in design and very easy to use, providing between 3 and 4 years of clean drinking water to each recipient.
Our goal is to continue to expand our program. In the first year, we provided over 100 personal water filter devices to individuals with the need in Pulaski County by partnering with local programs which provide services to individuals experiencing homelessness. For this calendar year, that has expanded to 2.5 times our original funding. We are actively seeking to find new sources of funding that would allow us to expand the reach of our program beyond Pulaski County into other parts of our great state.
We will be able to expand the reach even within Pulaski County as we attempt to study the current water insecurity status of the individuals who receive the water filters. We will follow up to determine if the filters have yielded positive quality of life changes for those experiencing homelessness and water insecurity. While data is important, we don't feel as though refusal of the survey should be a barrier to be a recipient of the potentially life-saving water filter. Thank you all for your time and attention.
Wonderful. And now I'm going to bring up the poster just so y'all can see that. Moment. And I broke it down to so that it would be easier to see, because a lot of good information on these posters, but sometimes Zoom doesn't make it so easy to read. So I'll go through each of these for just a few seconds so you can skim through it. And if you have any questions or comments, feel free to put them in the chat, and we can have John answer some of those. All right, let me stop this. And so we have one
Yes.
question for you, John. Can you describe what these units are, brand or description, and how long they will last, and do you need to replace them?
So it's Life Straw is the name of the brand. They're, if you've seen the large milkshake straws, they're just a kind of bigger version of that. They are each rated to last 1,000 gallons. So they do need to be replaced, but not for many years, kind of with daily use even. I wish I didn't bring all of them back to where we're housing them, or I'd pull one up. It kind of has a filter on the bottom. You remove the cap there. It has a lanyard so that you can put it around your neck or just put it in your pocket. It has a cap on the bottom where the water will be filtered up through, and then a cap on the mouthpiece.
Perfect. And I'm trying to bring up the website so I can put that link in the chat, so folks can bring that up and look at it. We have another question. What were the lessons learned from your first year of this initiative that could help sustain the future of this project?
Yeah, I think that lessons learned as far as getting things rolling from a procurement side, because the grant was awarded to UAMS, and then UAMS had to acquire these units, which we were able to get at cost by reaching out to one of the social impact managers at Life Straw. So we're getting them for about half of their MSRP. Additionally, I think that collection of data metrics, I think we were a little overambitious as far as we were trying to provide surveys as to what is your current water source, how do you think you would benefit from this, how does water insecurity impact your day-to-day. And I think having some data collection is important, but for a lot of people, they just kind of said, no, thank you, I'll take the water filter, but I'm not going to do your survey. So I think this year we're just going to do some more basic demographics, age, initials, and then ensuring that we kind of track as far as how many are distributed on what day and where. The majority of the ones last year were just given out. I would go to Jericho Way, either on mornings when I was off or weekends where they're providing free breakfasts for populations that need it, and kind of asking if people would be interested.
Oh, and Anna, this is a good question. So I'm from Flint, Michigan, with the water crisis. Luckily, moved to Texas 4 years before it happened. But Anna says, are there geographic areas in Arkansas where we have concerns about city or well water where these might be helpful?
We haven't really investigated as far as having these for household use, so to speak. They are rated to remove heavy metals in addition to antibacterial and antiparasitic properties of them. Because the grant was funded through the Pulaski County Medical Society, we're kind of limited in our scope in that manner. But we are trying to find other ways to acquire these and be able to distribute them to other populations. And if you have any leads on areas that would need them, I'd certainly be happy to hear those out.
Definitely.
I might even ask Dr. Wheeler not to at all put you on the spot, but a little bit. But I know you've done so much work on climate change as kind of our representative to climate change through the AAP. Is there anything you have come across in that space, Dr. Wheeler, with regard to clean water, access to clean water, that might be a good resource? And I'll also just mention the AAP's catch grants here as a potential resource for you. Those come out annually. So I'll send you some more information about that.
And I'm not sure where Dr. Wheeler went. But in the meantime,
Yeah.
oh, he's back. There you are.
Sorry. Yeah, Anna, good question. I mean, I think that clean water is an international issue for sure. And the impact of bad water is extraordinary. My project when I was in Belize almost 15 years ago demonstrated to me very clearly. I spent at least a third of my time down there with waterborne illness myself, and the ability to function is quite compromised when you're dealing with that, and its impact is even broader in groups of people who are vulnerable or societies there. So I mean, I think this is a great project. The way that this is handled in most countries is with Clorox. And that's just not something that's real accessible and available and portable. So these life straws, just looking at the link that Katie put up, look really cool and incredibly portable. And for something, a tool to be available, I believe you said for 1,000 days or something like that, or I can't remember.
1,000 gallons.
1,000 gallons, which may turn out to be about 1,000 days,
yeah.
is really an incredible resource. And I commend you and your colleagues for doing this work and introducing us to it.
Yeah, I'd like to thank all of them. I don't think they were on the poster, but Eric Porter, Hunter Wayland, Taryn Thind, and Zachary Waugh are current M2s. I kind of reached out. I didn't feel like I would have as much time this year compared to last to really kind of do the groundwork, so to speak. So they're kind of taking the lead as far as distribution of things. And Dr. Elizabeth Gath was the principal person on the grant and helped facilitate the transfer of money and the procurement and a lot of the red tape that was associated with actually getting these.
And John, I think we have time for one last question. So are there any ways that we can advocate for clean and safe water supplies in the city?
Yeah, I think that kind of addressing the city's unsheltered population more broadly, providing areas where at least during the day they could go somewhere and fill up a gallon jug, or just kind of addressing that problem as a whole. As far as specifically for clean and safe water supplies, I had considered they have basically a scaled up version of the LifeStraw where it's like a 10-gallon drum that you just pour water from wherever into, and then you use it like it's a water cooler. And if, the question is, where could that securely be housed and things like that. So I think that our approach of just, here is a water filter, here's how we have laminated cards that kind of explain, this is what it is, this is what it does, this is how you use it and maintain it, and kind of signs for, at the end of the time, kind of what's going to change about it, so that you'll know eventually it just kind of blocks up and is unable to function.
Wonderful. Well, thank you so much. And John, I know you'll probably be around too today watching the conference. So if y'all have any other questions, he can answer those in the chat. And now I will bring up our next poster presentation. Let me get this started. All right, and Anna, thumbs up again so you can hear it. Thank you.
Hi, I'm Daniel Liu, a clinical informatics fellow at UMS and Arkansas Children's Hospital. Thank you for giving me the opportunity to share my research today, using machine learning to advance telemedicine adoption. Like many other healthcare organizations, Arkansas Children's Hospital saw a rapid increase in our telemedicine utilization during the initial stages of the pandemic. However, as you can see in Figure 1, this was not sustained despite legal and technological improvements. Machine learning is a field in data science that combines artificial intelligence and large amounts of data to create accurate predictive models. So our goal was to use machine learning to develop a model that can accurately identify appointments suited for telemedicine using patient and visit details. This could be implemented within the scheduling workflow to help expand our telemedicine use. First, de-identified data was obtained from our EHR for telemedicine and office visits from January 2018 to March 2021. The data set was then randomly split into a training set to train the models and a test set that was used to evaluate how the models might perform in real life. The models consist of a label or dependent variable, which consisted of visit type and features, or independent variables, which are the patient and the visit characteristics that I've listed. 4 model types were selected based on literature review. The models were trained, tuned, then evaluated using precision, recall, and F1 scores. Precision is the same as positive predictive value, recall is the same as sensitivity, and F1 is a balanced score that takes both precision and recall into account. The model performance results are summarized in Figure 2. Logistic regression and XGBoost both had high recall but low precision, so they identified most of the true telemedicine visits in the test set, but they also identified a lot of false positives. Random Forest and CatBoost were more balanced. While they only identified just under half of the actual telemedicine visits in the test data, the visits they identified as telemedicine were 60 to 70% likely to be actual telemedicine visits. CatBoost performed just a little bit better than Random Forest, and you can see the actual results in Figure 3. So in conclusion, we were able to develop a machine learning model that has similar precision to other models that have been deployed in the scheduling space, but the recall needs improvement before I would consider implementation. I'm currently working on including the variables I've listed under next steps into the model, including additional relevant data typically leads to better predictive power, so we'll see if the recall improves. And that concludes my presentation. If you have any questions or comments, you can reach me at dliu2@ums.edu. Thank you very much for your time and enjoy the rest of the RAAP virtual conference. Thank you.
Alrighty, and now I will go back and bring up the poster. And just like the last one, we will go through and just slide through each of the different sections. And just take a few seconds for each one to skim and come up with some questions or comments that you may have for Daniel afterwards. That's that one. All right, and let me find Daniel and see if I can put him up. There you are. All right. Let me scroll through here and see. So if anyone has any questions or comments about Daniel's presentation, but right now, Daniel, if you want to go ahead and introduce yourself while we wait for those to come on in.
Hi, I'm Daniel. I'm a clinical informatics fellow. So that means after completing my residency a year ago, I've started further training in clinical informatics. So that covers building things in the EHR, which in our case is Epic, but also kind of data science type tasks as well. So thank you for giving me the opportunity to present my research.
Of course. Dr. Wheeler, did you have a question?
Thanks, Katie. Daniel, this is really exciting. One of the things that has bothered physicians for the last 20 years is the absence of physicians in the information models that we're working in. So congratulations for putting your toe into those waters. And I think your question is a really great one. And I just wanted to make sure the presentation was a little quick for those of us who are a little slow to understand all this. But one of the answers, it seems like, to the poor recall effort is that of the telemedicine visits that were made, maybe they weren't appropriate a lot of the time. Is that a correct possibility, or was that excluded by your work?
So the appropriateness of a telemedicine visit can be difficult to judge, since we could look at, things like, did they go to the ER afterwards? But if it was used kind of in an urgent care type situation, sending the patient to the ER may be appropriate. So outside of kind of manual chart review, I think it'd be difficult to determine if a telemed visit was truly appropriate or not. So that does factor kind of into the equation. I do think that as we do more and more telehealth visits, that will give us more information and possibly kind of help with that.
Thanks.
All right. Are there any other questions for Daniel about his poster, comments, or anything like that? And I will also go ahead and put your email in the chat because I know you are busy and giving out vaccines today. So you don't have to stick around too long. So if anyone thinks of any questions, they can shoot you an email and let you know.
I'll just say, I think this is a really interesting, I know that in thinking about community pediatrics practices who have adopted telemedicine as well, in some cases, I know it's something that patients do love, and just thinking about how some of your learnings could be applied outside of a healthcare system, but more in a community practice. I'd love to continue to think about that. If you think it is directly portable, I guess, to the community practice setting, I'd be curious to know if you think that your learnings translate directly, or if there's something else that should be considered in that space.
Sure. So that's a great question. I think the answer will kind of be, it depends. If a community pediatric office has been collecting kind of the same sorts of data on their telehealth visits, then I could certainly train a model essentially kind of for that data set. I would probably be hesitant to apply my model to those situations, given that this is, we're a larger academic institution. So the patient populations can be different. The way the patients like telehealth can be different. And so I certainly think this is something that kind of, if you have the data, that could be done. But the variables I collected for this initial model are pretty straightforward, mostly demographics, and then a few visit characteristics. So I don't think there's kind of too much of an ask on the data side. So this could certainly be kind of train for a local community practice if they have the data.
Thanks so much, Dr. Liu. Appreciate you.
Well, I believe that's all of the questions we have, but again, his email is in there. It's got to get back to giving, vaccines, which is far more important, I must say. But thank you so much for taking time out of your busy morning to be with us and answer these questions. And thank you to you too, John. These were great poster presentations. We really appreciate y'all for submitting those to us. Again, the contact info is in there for any of our participants who have questions or comments or just want to get in touch to learn more about those research. So thank you again, and we will move on to our next presentation.